Okay, that's recorded now.
Great, thanks very much. Okay, morning everybody. Thanks for joining the December governing body in public, and this is going to be shared by teams, by recorded teams on the website later on. Great to see everybody here today. Just a couple of things to note, that we've got apologies from Simon Bell, Andrew Moriarty and Sharon Stoltz. But first of all, what we're going to do is just to have the question from the public, and this was from Virginia Hatton, York Home Birth Support Group volunteer. And this question was, what plans are there in York to provide a sustainable and accessible home birth service? And that's in fulfilment of the Better Births target to offer personalised care, which includes choice in place of birth. When will continuity of carer be available in York to all birthing people, including those who plan home births? And I think, Michelle, you're going to respond to us, if that's all right.
Good morning, everyone, and thanks for your question, Virginia. I'm just going to read it out word for word, because what we will do is make sure we email this back to you, Virginia, because it's also a link that might be helpful too in the narrative. So, due to the challenges within the midwifery workforce, the Trust is ensuring that core safety of mothers and babies by assessing staffing levels and how they match patient care needs, often referred to as acuity. This has meant that decisions, although not taken lightly, have needed to be made to suspend the home birth service on a very regular basis and transfer some women for delivery to alternative hospitals. The Trust position in this has been reported daily to the regional chief midwife and on a monthly basis to the CCG. This, however, is not unique to York Hospital. Following wide consultation with midwives, NHS England has issued new guidance to maternity providers regarding planning for delivery of the midwifery continuity of care. Revised guidance is available following the link, which I'll put on this when I email you back, and we'll make sure it's on the website. Delivery of continuity of care requires more midwives than traditional models of maternity care. This guidance has considered the challenges that many have faced in maternity units and is clear in its advocacy to ensure that building blocks are in place for sustainable delivery of continuity of care. In line with this, the Trust is required, alongside the local maternity system of the ICS, to agree a plan that describes how it will achieve continuity of care as the default model of care offered to all women by March 2023. This will include putting in place the building blocks for sustainable models, which are described on the link in the guidance, of continuity of care by March 22. And this plan is required to be submitted by NHS England by the 31st of January 2022. The Trust is currently working through its workforce plans and how these will progress stage by stage to the expansion of continuity of care offer and a sustainable home birth service. This, however, is fully dependent on the availability and ability to recruit additional midwives. These plans will be shared with the CCG ahead of the submission to NHS England by the end of January 2021.
Great, thank you very much, and we'll make sure that that response is sent out as well. So that's great. Thanks you, Virginia, for the question. Thanks, Michelle, for responding. Okay, just going to go next into the agenda. We've moved the agenda around a little bit, so the staff story is going to come after the accountable officer update, just because Steph, who's going to update in that with Phil, is needing to leave at 10 o'clock. So if there's any issues with the minutes, can anybody tell me that? Otherwise, we'll approve those. Okay. There was one matter arising out of the minutes, and that was a safeguarding update. And Michelle, I don't know whether you wanted to pick that up now or in your report.
I can pick it up now. So yeah. That'll just be slightly delayed because the nurse that we've appointed as the transitional safeguarding lead for the ICS is going to do that work, and she starts next week. So as soon as she gets going, I'll come back here, probably January.
Okay, probably February then. Put it on the February one. That's fine. Yeah, that's great. Okay, and just for people to note also that might have seen on the public papers, there's no specific finance update on the agenda. Due to the timing of the notifications of allocations and planning guidance, but Phil will probably pick up on a few bits and pieces around that he wants to just highlight. Okay, so if that's okay, Phil, should I come over to you to present your bit and also to introduce Steph?
Yeah, okay, thank you. We'll do. Morning all, morning everybody who's watching this on the recording. So I'll briefly pick up finance, as Nigel mentioned. I'd like to talk about transition, but before I do that, Steph's going to outline for us some of the activities currently going on in response to service pressures, and in particular an outline on progress with the vaccine.
So I'll start with the vaccine. Good morning, everyone. It would be fair to say that this is a fast-moving picture. Anybody watching the national news will know that we heard from the BBC midday, and then we had an evening briefing at 6 o'clock about the booster programme, your eligibility reducing from 6 months to 3 months. So we now have a requirement to stand up our services to be able to offer and deliver as many booster vaccines to our population. Now, in the country as a whole, the vaccine programme by and large has been delivered through primary care. 75% of vaccines delivered have come through our extended primary care, supported by a fantastic set of volunteers. But when we talk about suddenly standing up millions and millions and millions of additional vaccines, it is going to take a bit of organisation, and it's going to draw on trained, skilled resources that have already been delivering the vaccine programme. So to date, for the Vale of York population, we've already delivered over 5 million vaccines. That's jabs into arms that have contributed to the breaking the link of our vulnerable patients dying from COVID, going into hospital and placing more pressures on hospitals, but they are delivered by our existing services. So we just want to put that into context, really, that as people, our citizens will appreciate, our staff are working incredibly hard to deliver on a whole range of priorities. We know we have a backlog due to the pandemic, and we're juggling all of those priorities. So just to give a bit more details about the vaccination programme, we're currently delivering vaccines using Pfizer and Moderna. We have a small supply of AstraZeneca if people are clinically required to have AstraZeneca. But just again, to get into a little bit of the detail, both Pfizer and Moderna need a 15-minute observation period. So to get through the volume, either we take longer to do it because we don't have stadia that we are delivering the vaccines to. We are delivering them in our existing buildings, or we put more vaccine lanes on so that we deliver more people and they take the 15 minutes observation period. To put more lanes on to vaccinate, we need more staff. Our admin staff, our clinical staff, and our fabulous volunteers. So you can see where I'm going with this. We are drawing in resources, and every vaccination service up and down the country is doing this. So absolutely fantastic that there's 400 people from the MOD joining our ranks. But actually, we're relying on our existing workforce. We deliver services for the vaccine programme at Aston Bar in York. We've done some work at Tadcaster Health Centre, but the primary south locality delivery area is the Summit at Selby, and we continue to deliver vaccines at Pickering Medical Centre and the Galtrees in Easingwold. And then supplementing that, we've got more and more pharmacies coming on board, plus what we call pop-up centres. So people remember we've done them in York City Centre, we've done them at the university, we've done them at Askham Bryan College. I could just go on and on and on. But as of the 1st of December, we are looking at first and second doses, so primary, that primary first allocation of anywhere between sort of 85, 95% vaccination. We've got some notable areas where there's low take-up, and we're addressing that. In the City of York, there's still 30,000 citizens who have not received their first dose. And I would urge anybody who still needs their first dose, we are still there for you. We'll continue that campaign, and we will make it even easier for you to get that first dose. It's really important to us. And in light of the question that we had at the top of the meeting, I just want to talk about the exceptional work that our maternity professionals with our vaccine team have done delivering vaccines in antenatal clinics recently. This is one of the lowest take-up cohorts of people, pregnant women, and we are now we've got now the highest vaccination rates in the region, so people are coming to us for best practice. Still lower than where we want to be, but I want to just acknowledge that work that's going on. So yeah, a lot to do with the vaccine programme. We're approaching our 1-year anniversary. Just to remind people that we've been vaccinating for 12 months now, pretty much non-stop. So, as I said, over 5 million vaccines delivered. So thank you, everybody who's been involved in that. Thank you for supporting. We don't want wasted vaccines. We don't want untaken up appointments. So I thank all our citizens who have contributed to that. So together with good hand hygiene, social distancing, getting your vaccine is one of the, if not the most important thing that we can be doing to support ourselves, our families, our loved ones, and society in general. So really great stuff, but the next literally boost in vaccines coming on board now. So do we just sort of move on from the vaccination programme? We know that winter is a traditionally exceptionally busy time across health and social care. So there's more respiratory virus around. We have delivered our flu programme. We're almost at 100% for both COVID vaccinations and flu vaccinations in care homes. Again, more our elderly population that we know have the greatest vulnerability to all of these respiratory viruses, actually. So we're working with primary care colleagues, particularly in general practice, to look at how some additional funding that has come on stream to support winter can be used, how groups of practices under their primary care network and wider can look at efficiencies for delivering care. I just want to highlight that you hear a lot in the press about access to primary care. In the Vale of York, for September 2021, we delivered another 10,000 appointments in comparison to 2019. So there is access. It is fair to say that the combination between having a face-to-face appointment and a telephone appointment, that changes, and there is variety in that. But after a telephone triage, if clinically appropriate, you can access face-to-face appointments, and we're, as I say, we're about 70% of the total appointments. The recent Health Watch report cited some really good examples where our citizens have reported excellent access to our care. They also highlighted those areas where people had identified that they have a preference for a face-to-face appointment, that some of our telephone systems, particularly on a Monday morning, feel very pressurised and there's long waiting times. And actually, we know that there's more that we can do for people who aren't digitally enabled, either they live in rural areas and Wi-Fi is poor, or people just aren't good or choose not to use online access to primary care. But over the winter months, and this has already happened, our primary care networks are looking at how they can deliver more capacity. And we do that thinking about how we work together as a whole system. Our voluntary sector colleagues, our secondary care sector colleagues, we're all focused on trying to work through demand versus capacity. And we know that that demand is outstripping that capacity. So if there's anything that you can do to help us thinking about when to access the right care, different forms of self-care, using community pharmacies, that would be very much appreciated. So I'm going to pause there. I think that's a lot of information about the fantastic work that primary care colleagues are doing. And I am going to be departing shortly from the meeting, so to continue just making sure that we've got support in the system to do that.
Great, thanks, Steph. I don't know whether anybody wants to maybe come back on a few points or anything you want to.
I just wanted to add that, as usual, Kev Smith from Public Health gave a really fantastic presentation about current data around COVID-19, and there is no doubt that we are definitely seeing an impact of the booster programme on the health of individuals. It cannot be underestimated. You can see on the graphs what's happening there. So it is extremely important that people do get that booster dose, and your immunity will wane just from your second and first doses if you don't do that. And discussions are continuing about how often we will need boosters, and that's not very clear yet, but it is having a significant effect on the population and hospital admissions, so it's really important.
David.
Is there any noticeable difference between the different brands?
No, and actually the evidence does suggest that it doesn't matter what you get for your booster. Go for what's available, and actually there is some suggestion that is beneficial to mix them up a bit. Yeah, so people shouldn't worry about that and take what's available.
Helena.
So I just wanted to highlight that I just did a quick run on the numbers then, that there's been a 10% plus increase in normal appointment activity before we start counting the vaccination activity in practices, and you'll know in our area we're doing them in practice. So that without counting any of the vaccinations, we are seeing such a massive increase in demand, and we have increased our capacity. And I suppose I just wanted to flag the genuine concern we have about continuing the vaccination programme and the impact on general practice, and how difficult the decisions are as GPs and as practices as PCNs about which activity you prioritise in the absence of more people to come and deliver vaccination. That's quite a compromising position to be in, because although we are offering more appointments, we don't have any more people to run programmes, to organise things, to coordinate stuff, to book people in. We don't have more reception staff, we don't have more admin staff than we used to. Because I just wanted to flag the pressure and difficulty in making decisions about who does what and how.
I agree, and there's a boiling pot, isn't there, between frustrated citizens accessing services, on occasion taking their frustrations out in our staff. That's not acceptable. That then leads to our staff thinking, actually, why don't I go and work elsewhere? And we are genuinely seeing that. So there isn't an easy solution to that, is there? We can't, although we are recruiting, training more people, we want we want people to be skilled, and that takes a bit of time to come through into the system. So yes, I acknowledge that we are in a bit of a tipping point really with demand and supply.
Julie?
Yeah, and sort of on the back of that really, it's just for people to realise when they ring and someone answers the phone, that's a normal person that's got probably all the same kind of problems you've got going on in the background, and yet they turned up for work to try and deliver their job in the best way that they can. And, and abusing somebody in that position is absolutely abhorrent. So think if it was you sat in their place, how would you want that conversation to go? No, I'd want somebody to be polite to me and understanding and actually listening to what I'm saying.
Yeah, no, absolutely.
So we would appreciate it.
Yeah, and that's something that we want to emphasise, isn't it? About
It is
kindness and compassion to our
Absolutely.
primary care staff. I know, Steph, you're going to have to go in a minute, so please just go when you need to go. It's not a problem. We'll continue the discussion. Phil.
Thanks, Steph. So I suggest we do two things. One, we do a comms media piece on behalf of the governing body, encouraging take of the vaccine and the booster, and we do that ahead of this weekend, and we try and make that an impactful contribution, because there are many comments in the media and more widely about the vaccine programme. So let's find a way of doing that in an impactful, authentic way that has authority. And then secondly, I suggest we write on behalf of the governing body to all of our practices, recognising the work that they have done, are doing and will continue to do, and thanking them for that, and also making a comment about how we will continue to support them over the winter period, particularly where they're facing abuse from patients or difficult behaviours. If we could do both of those things on behalf of this governing body, I think that would be worthwhile. Yeah.
Yeah.
Just on that comms piece, if we can try to avoid getting patients to directly contact duty practices and clogging up the phone lines for people who need to get through the clinical need, because that's already happening, I think, in light of what the government announced on the BBC. Yeah.
Great.
Okay, brilliant.
Thanks, Steph.
Thank you, Steph.
I suppose the last bit around support for general practice or primary care is about the ethical dilemmas about what to stop and what to concentrate on. And there's a bit of system work going on at the minute around setting up a systems ethics panel around Humber Coast and Vale, which is the emerging ICS, around difficult decisions and defensible decisions and recommendations out of that. So it might be something that we could do to bring to that.
Yeah, I think that's the problem that all the practices are grappling with. And we think about our CQC, sort of safety and effectiveness and being well led and everything else, and we are compromised. And I think one of the simple things is if you think about there being a 10, 12, 15% increase in appointments plus booking vaccinations in, the phone lines are 20-30% busier. That's a nice familiar sound.
It's nice to hear it back, isn't it? Hopefully I've saved you that. Right.
So if the phone line is 20-30% busier, there's a safety issue there straight away. So it's just, I really feel for our patients right now. I really genuinely feel for our patients. And it's a very difficult, like you say, ethical decision about where you place your priorities. And urgent care is very, very important, by definition. routine care is the thing that prevents urgent care. And, you know, we're not going to get out of this by just focusing on the urgency.
And inequality is widening.
We've talked about, you know, people accessing the internet, and that's a major inequality. Not only because of the links that people have got, or maybe they're, you know, they're over a certain age and they don't want technology, they don't trust it in their house. It could be that they're from one of the poorer parts of you know, of society, and they just can't access it.
Yeah.
And that's, you know, that's heartbreaking, really.
Yeah.
Consistency of practice though is key. Where you guys get played up against each other, that's where it gets, in some cases, immeasurably worse. And while each case has its own, will have its own unique features, actually what you're right to wait for guidance that is giving you that consistency of practice.
Yes, unfortunately, I don't think that guidance will come centrally because it's too politically hot. Just understandably, I understand that, but it's not helpful. I think the other thing about the model of UK general practice is its uniqueness of being able to mould itself to its rurality, geography, populations that it does. So there are some bits that we need to standardise, but there's some bits that definitely need that flexibility, isn't it? And that's difficult in itself. And we know this around this table from the different populations that everybody sort of represents. So yeah, absolutely. Great, thanks very much for that, and thanks to Steph for doing that. Bill, do you want to keep going with your accountable officer update, and then we'll get back into the agenda?
Yeah, thank you. I'll do that. If you could take my report as read in the papers, just in terms of the comment Nigel made about finance, you remember that the half-1 position was delivered as planned, and Simon Bell had concerns about half-2. That was discussed in a bit more detail at Finance Committee last week. Simon's concerns are easing, but half-2 still considered to be greater risk than half-1. We'll continue to use the Finance Committee to make sure that we have an accurate oversight of that, and we're in a position to take any decisions that we might need to make on behalf of the CCG to deliver the end of year position. I'll leave that there on finance unless any members of the Finance Committee want to comment.
Just to say that we are assured that Simon and his team are keeping on top of this, and they're in a very difficult position with lack of notification and planning as we move towards new systems. But I think as lay members we could say we've gained assurance that everything possible is being done, and happy to give assurance to the governing body that our finances are in the best order they can be.
Yeah, thank you, David. So I'll just spend a few minutes talking about transition now, if that's okay with everybody. So colleagues will probably know that the Humber Coast and Vale Integrated Care Board designate positions for chair and chief executive have been announced, and they're publicly available, and the ICS has been named. So all of the 42 integrated care systems have a name. Those names have been determined nationally. So the Humber Coast and Vale ICS, as it currently stands, will become the North Yorkshire and Humber Integrated Care Board from the 1st of April, subject to legislation proceeding as is proposed. There's now a timetable for appointments to the board that includes both executive and director positions. The same for lay member input to that board. Some of those posts are subject to national process. All are subject to formal appointment processes. Running alongside that, there is a consultation exercise which has a number of phases to it for affected staff. We know there will be at least 2 phases. Phase 1, directly impacting this CCG staff, started on the 22nd of November and it runs for 30 days. Phase 2 will start in January, probably the second week in January. The timetable for phase 2 not yet agreed. Phase 1 requires all affected staff at board member level who have a contract to engage in briefing sessions, and creates an opportunity for them to also have one-to-one conversations about the establishment of the ICB. Phase 2 will start to make those conversations more personalised in terms of the careers of directly affected staff at board level. For staff below board level, the ICS are now doing regular briefings for all staff, providing an update on progress with the ICS, and many of this CCG staff are attending those virtually. That provides an opportunity for questions and comments. So things are starting to move in that respect. The transition period that we're now entering has some risks associated with it for this CCG. So where there are aspects of our work that are system facing, there are a number of interim positions being created to manage those work programs on a system basis rather than on an organisational basis. That means that individuals leading those areas of work are now creating capacity to support them. That capacity requires individuals involved to do not only their CCG work, but also that system work. That is placing an additional strain on those individuals involved and has the potential to create gaps and risks. At the moment, I wouldn't suggest that's a risk we would want to include on our risk register. There are no known areas, other than there are many known areas where we have, through the executive committee, an active overview of that changing position, and it will continue to change and accelerate in terms of the difficulty it may create for making sure that we cover off all of the CCG duties. From next week, we'll be using the executive committee and the deputies session to manage that transition on behalf of the organisation. So the executive committee will make any decisions on behalf of this governing body, and we'll work with the deputies session to make sure that it's got a visibility on all of the issues that we think we need. I'll do a sort of brief terms of reference for that for the deputies, just so that their role in that is clear. I'd just like to thank and commend the deputies for the work that they've done, the goodwill that they are showing, and the hard work that they are putting in goes way beyond what we would normally expect of that group. They're a really great group of people. Do great credit to this CCG. So as the Integrated Care Board now is starting to mobilise toward its shadow arrangements, this CCG concurrently is mobilising a due diligence process for the disestablishment of the CCG. That is something that the executive committee is overseeing. But much of the work is being done through the deputies group. So that's an example of how that dynamic will work that I just described. It's an extensive exercise and not terribly fulfilling, but quite important. But quite important.
Can I just put in for a moment?
Yeah, please do.
Our staff time to talk event, one of the questions that I raised was around the support for our staff from HR, because I think it's really important, and staff are going through such turmoil anyway, trying to balance COVID and doing the day job as well, plus the changes. And I was absolutely reassured that not only have we got enough HR, but the staff and support, the support within our organisation. So that's with the team leaders, but also there would be an additional staff available. So I just wanted people to realise and to reiterate that to anybody that wasn't there or that hasn't logged in yet and looked at the YouTube channel.
Great, thank you.
Thank you, Phil.
Yeah, thanks, Julie. But although I agree with what you said, the changing pace of this and its impact on the emotional well-being of staff over the next few months, we might need more HR support than we've currently got. And so what you've just described might not be the case as we work through this.
Yeah, well, I was told there would be additional, because I did ask the question if we haven't got it as a gift already, and I was assured that there would be extra. So I'm hoping that there is extra.
Keep asking that question.
I will keep asking that question.
Keep asking that question. So just in terms of the due diligence piece, then we therefore will have to consider how many more meetings of this governing body to hold in public session. Nigel and I have discussed the feasibility of 1 or 2 between now and the end of March. There's some form of close down in public required. We don't know what form that will take yet or when, but that's something that this governing body should all agree to. So that's something to think about. We will, until the 31st of March, make sure that all of the committees continue to take an overview of all of the quality and safety issues on behalf of patients and also the financial issues. What we don't know yet is what we do with things like audit committee after the 31st of March in terms of sign off the account. So that's again something that we will have to clarify. So we'll keep the subcommittees running, this governing body 1 or 2 meetings in public. Welcome views on that now or after the meeting, please. And then just to finish off, so whilst we're doing all that, still trying to establish successor arrangements in places. So North Yorkshire as a place, York as a place, and 4 in the Humber. The work that we are doing on that is somewhat constrained by making sure that our attention is on services and not too much on structure. Also, we can only progress that at a certain pace because the HR framework around the transition means that we can only go at that pace. An example of that being it's suggested that each place will have a lead officer director. That's not progressing quickly because of the HR transitional framework. So that's still to be worked through. And the schedule of delegation to which each place will work, so the governance of place that will replace the governance of the CCG, still not developed yet either. Some of that can only be developed when the ICB shadow arrangements starts to consider that from its own perspective as well, in terms of whether places would have a subcommittee of the ICB or there'd be a joint committee of the ICB or something else. So those governance discussions are now starting in places, as well as will start at the ICB. And what I would hope we will see is that there'll be a harmonisation of ambition there, but that will depend to an extent on what everybody thinks and what everybody wants, and who's in post in terms of the ICB.
Yeah, the personalities involved.
Yeah, but that work is progressing. York is still as well advanced, if not more advanced, than many other places. North Yorkshire, because it's a combination of lots of smaller parts of the geography is coming together, but probably from a governance and leadership perspective, not as far advanced yet as York, but that work is being led by North Yorkshire CCG, and some of the Vale of York team, Fiona Belmorrit and others, are actively involved in that, and hopefully our parts of the Vale will not be disadvantaged in terms of that pace as we get to April, and we're doing what we can in the Vale to make sure that that's the case. I'll probably stop there, but very happy to take comments and questions on all of that.
Thanks, Phil. Chris?
Wow. You know, we just heard about what Steph's been dealing with, what GP's dealing with, and then there's this going on. I think, you know, that needs some equal recognition, isn't it? That's a huge piece of work. What I'd like to see in terms of this governing body, the CCG transitioning, is doing what I feel we've always done, which is take a lead in our own fate and destiny. You know, this, I think in the last 3, 4, 5 years, this organisation has really done a lot of really good things, and I'd hate for that momentum at the end just to so if the ICB are not yet in a position that they can start to describe the governance at place, I'd like to see the people in this organisation start to describe that, and so they can say that to the ICB and say, this is what we've been doing, this is what we'd like to keep doing, this is how we see it working. You know, it's another piece of work to do while they're trying to tackle everything else. But I think the strength in what's happened over the last few years is because of the relationships built locally, and I'd be really keen to see that. Yeah, momentum kept up.
Yeah, thanks, Chris. I can only agree with that. So certainly in York, on behalf of the Alliance, that thinking is taking place, and the discussions are at an early stage. They now need to accelerate a bit. What probably is required across Humber Coast and Vale, or North Yorkshire and Humber as it will become, is 1 or 2 places to do that work for others to follow. I think that's probably what we will do.
Yeah, which is exactly what I was. So I think it, you know, coming back to the staff wellbeing thing, I think if people feel engaged in the future and have some, you know, some steer of what might come rather than be done unto, it might, you know, it helps. Yeah, it will certainly help me to feel I had some control over what was going to be my job.
I think it's very much when we're thinking about our patients, no decision about me without me, and I think we should afford that dignity to our staff as well, and you know, right the way through.
Yeah, and the other thing I didn't say, but probably should, as part of the risk, all CCGs, and now this CCG, we are losing staff.
Yeah.
So as well as the establishment of interim posts, which I've already mentioned, a number of staff, because of the uncertainty, are choosing now to find other opportunities, either with providers or other parts of the NHS, or outside of the NHS. It is becoming thin.
Yeah, I mean, the word that keeps coming into my head as you're talking and describing this is turbulence. And off the back of Steph's comments, it strikes me as a very unhelpful time to be experiencing such a high degree of turbulence, and to lose staff in amongst that is really difficult. I think the other thing is that it's in terms of an employee's perspective, it's a buyer's market. There are so many holes in recruitment, whether it's as a nurse or indeed as a GP or as a member of the CCG team. So retaining staff is really important, isn't it?
Yeah, it is, and it's not easy at the moment to maintain the environment that we've created, fostered over recent years and months, that given the staff the confidence that they have had. So it is becoming thin. I spoke to a commercial provider of interim support yesterday, who said they're turning work down and have done for some months. You can see what's starting to happen.
Yeah, probably not very helpfully, but I mean, I'm speaking as an independent lay member here that only the current government could impose the reorganisation on the NHS at this precise time, with obvious consequences. There's nothing we can do about that, except that I agree wholeheartedly with Chris that the really good ideas for patients that we've been trying to promote, I'm really worried that as we move into the ICB now, what's going to happen to all those, who's going to champion all those good ideas and those services that we've managed to create? And that, no solution, but it is a real worry. And it is, for each of us around this table, wherever we're here, to try and make sure that they continue, they're not just disappear into the ICS is taking over, and so on. I think it's a real, issue for us.
Those voices are still there, though, and I think that's we talked a little bit about championing hope recently, and I think that whilst ever this turbulence is causing quite a lot of difficulty for a lot of people, there are still lots of people who want to do really, really good work, who retain that organisational memory. And so my hope is that once we get to the other side from April onwards, that calmer sea will come when the ideas and the work starts to take centre stage again over the organisational structure. Because I don't think those people have gone away. Some of them have. They've retreated, but most people are still out there and probably quite energised by, as we said, the widening health inequalities gap and the real crisis that there is in communities over healthcare. I just want to inject some degree of hope.
It's an old military adage, isn't it? Prior preparation and planning prevents poor performance. Just picking up a few of these things. Phil, you talked about some areas, as people in the CCG and the CCG itself gets stretched, and indeed latterly you talked about as resources get denuded, some areas of risk bubbling to the surface. What sort of areas are they? Is there anything that we can do to help you and your team on the ground with them?
Oh, crikey, where do you start? So Michelle and Denise would say, can I have 20 more nurses, please, each? Nursing is thin across the system. This CCG is no different. So the work that we do supporting the care sector, the work that Denise's team do every day on managing complex patients, it's becoming more and more difficult in that space. I was going to use the word fortunate. It's not fortunate. We have always enjoyed, for a reason, high calibre, good quality support and management into primary care. Other parts of our NHS across the ICS have not enjoyed that level of capability and capacity. It is in demand and therefore is becoming stretched. So our PCNs who've hopefully had a good relationship with the CCG in terms of support, information and knowledge, that's going to feel different during this transitional period and possibly beyond. So they're probably the main two.
I would just add, though, that with every member of staff that leaves us, we always think, what's the opportunity to do something different? Because we can't afford, we haven't got the luxury of replacing like for like. Because who is going to want to come and join CCG that's about to exist? And there are recruiting processes in place across the ICS, which the basis is offering opportunity to our people across the ICS list, and that's the right thing to do. So there are processes in place to do that. But I'll give you an example. So Karen McNicholas, who we know and love as our lead nurse for quality for children and young people, has gone on to convent to manage the Children and Young People's Transformation Program across the ICS, of which it's the same work as CCG's, and actually our ambition is even higher than that, but across the ICS, and gathering in and making a huge network of really passionate people about children and young people who want to advocate, who haven't really had that connectivity across the system before. And actually what we're finding is so much great work going on that we as places can take and adopt and learn from. But within the CCG, what that's led us to is to think, well, actually the work on SEND, of which Louise is part of, has led us to think, well, it's the same for every local authority. So why have we got two separate teams in North Yorkshire and York CCG doing essentially the same thing? So with Karen's departure, that's led us to set up a joint North Yorkshire and York SEND team. And we will increase the recruitment to that, but at a different level. To match Louise, but in North Yorkshire, but then to work cohesively as one team. So sometimes it is great opportunity and things can be better on the back of it. It just requires a different mindset and sometimes a leap of faith to do things differently. But that's not to say there isn't risk all over the place.
Yeah, thanks. Great. Okay, thanks very much, Phil. I suppose a couple of reflections from me. One is the great work that the deputies have done, and I know you highlighted this to me a couple of days ago, Phil, so I just wanted to echo your thanks to them and as a governing body to the work that they've done, and also the extra work that they've done that they didn't need to do, but they've done. So that's really, really appreciated, and I want to thank them for that. The other thing probably to think about is the real work that's been done over the last 3 to 5 years, and not losing that, like you say, Chris. And if we went back to Myron's bits, he would say, well, real change happens in real work. So it's actually getting into that real work that we need to do. And so that's the inequalities and all of those good things. So yeah, absolutely. Great, thanks very much, Phil, for that. So we've moved the agenda a bit around. So we're actually going to go back to item number 3 now. And Louise, you've been very patient. Thank you very much for this. And Michelle, are you going to introduce this? This is the staff story. So over to you, Michelle, and then Louise.
Thank you. Thanks, Louise, for spending some time with us. So you know that we favour bringing the patient story here on a regular basis, but we thought it was important to bring staff stories, and this is one of those. So Louise came to the Quality and Patient Experience Committee. Louise is part of the Quality and Nursing team, and it's a brand new role that she does, and we forget that she hasn't been here forever now. And it was instigated on the back of the written statement of action that we received with City of York Council on our SEND framework application. And there were some gaps for health that needed to be strengthened. And so Louise was brought in to do that. Not done it before, not a blueprint before, a previous role before, but has grasped it, and you'll read from the papers how positive that's been for children, young people and their families across York. So she's come to tell us how it's been and what she's achieved and what it means for her as a member of staff. Over to you, Louise.
And thank you, everybody. Can you hear me okay? Is it?
Yes.
So I've just popped a few slides together in PowerPoint, so I will try and share them. Right, hopefully you'll be able to see the PowerPoint and not my very large face on your screen. Can you all see that?
We can, yeah. Brilliant,
super. Brilliant, thanks very much. And again, thank you so much for giving me the opportunity to share my staff story with you. And as Michelle says, I've been in post with the Vale of York CCG for the last 10 months now, so started February 2021. And I've got to be honest, before I applied for this job and saw it advertised, actually, I didn't know what an Associate Designated Clinical Officer for SEND was, or what a DCO for SEND was. So I had to do quite a bit of digging and reading to see if it was a type of job that I would be interested in doing, and also that I'd have the skills and knowledge to do. So As I said, I was an associate DCO, and different areas have different sort of models, and Vale of York have opted for the model of, as Michelle says, Karen McNicholas was a sort of lead for children and young people, and then an associate role. So my role is sort of more operational basis. But when I did some reading around, the things I found out that it's currently a non-statutory role. However, Ofsted and CQC have identified the role as a really important element of rolling out the implementation of the Children and Family Act reforms that were 2014. And they've highlighted that it's an important role to support CCGs, ensuring that they're meeting the statutory duties for children and young people with SEND. And the specific roles vary between area to area. So as Michelle says, I'm working very closely with North Yorkshire now, and there's a plan in place to work even more closely together. But generally, the key sort of areas of responsibility are oversight of health needs and provision for 0 to 25-year-olds with special educational needs and disabilities. It's a coordination role in terms of working with local authority, health providers, parent care forums, and advocacy groups. And there's some strategic sort of joint commissioning overlap where I work really closely with Associate Joint Commissioner Susan de Vale, and work really closely with the local authority in ensuring sort of active participation and co-production, and making sure children and young people's voices are at the heart of what we do, really. So that's a generic role of DCO. And I suppose the role does require quite a bit of sort of clinical knowledge and experience. It requires somebody to be able to work across multi-agencies and have a good understanding of health services and local authority working. And so when I saw all this, I thought, oh yeah, I've got the skills and experience to do that, so I will apply. And my background really made me sort of feel like I was adequately qualified and experienced, and that I'm a children's nurse by background, 23 plus years now. I've been a paediatric nurse, and I'm also a health visitor did my health visiting training about sort of 12 years ago. So I felt quite suitably experienced to apply for this job. My other roles previous to health visiting were sort of acute and secondary care within community settings, and most recently, working with children and young people with diabetes as a clinical nurse specialist with teenagers, actually. So that involved a lot of sort of education, working with education and local authority. So I felt quite prepared and quite able to take the job on. If somebody had asked me to sort of put myself on the novice to expert, which is a nursing, a USA nurse and theorist and educator, Benner, she's called, if they asked me to put her on the ladder of proficiency, I'd say that before starting the job, I thought I would be fairly proficient at it. That I've got a significant amount of experience children and people working, and safeguarding, for example, and working with children and people with special educational needs specifically. But when I first started with the CCG and in the world of SEND, it became really apparent really quickly that I had underestimated complexities of working within a CCG across 3 different local authority boundaries, and with multiple providers, in addition to the world of SEND, which is quite sort of complex. And so this was a word search that I put together when I presented to a national sort of DCO forum, and it just sort of outlined to me how, in the first couple of weeks, all these acronyms were being talked about, and at every meeting there was something I had to write down in my shiny new jotter and go away and investigate and find out. So this just sort of reflects that the first feelings that I had in the first sort of few weeks and months. When I sort of got into post, I went from feeling quite proficient to quite unconsciously incompetent. I didn't know what I didn't know, and it took me a little bit of sort of chatting through with my nursing quality colleague friends, and especially Karen, as Michelle said, had a lot of support from Karen in the beginning, to kind of start to sort of boost my confidence and feel like I knew where I was going. But as Michelle says, York has that written statement of action, and that provided a really good sort of sound basis to start my work, and to know sort of where I needed to progress to. So I thought it's just helpful to run through roughly what I actually do. I'll sort of pop that up here on the slide for you. But one of the key things that takes a lot of time really are the multi-agency panels that I sit upon, and the key one to that is the Education Healthcare panel. There's quite a bit in the report about what that looks like and what the purpose of that is for, but really my role is to make sure that children and young people's health needs are identified within those education healthcare panels plans, and that the provision is going to in the plan to meet those needs really. And if there's any provision that's in there that is not currently commissioned, then obviously I have to escalate that and discuss it with my commissioning colleagues. So that takes quite a bit of time, but sitting on the panel really helps. It really helps me sort of look at the quality of health advice that we get from our health providers. So I've been able to sort of look at individual cases and take up with health providers the quality of the advice on individual cases. I've also been able to do a sort of a snapshot audit of the health advice returned, and also about how many teams are involved with children and young people when they are being considered education healthcare panels. So this is the full sort of report that you have in front of you, details all the kind of audit that I did in July to September, but it's just like a little flavour of it really. So in that period of sort of 7 weeks, there were 49 children and young people considered at EHC panel. And out of those 49, actually 47 of them had health teams actively involved. So that's somebody in addition to their GP. Out of those 47, 40% of them actually were known to our CAMS services. So you can see that that's got a massive chunk, 40% known to sort of our local CAMS services. The children and young people who come to EHCP panel have an identified primary need as part of the SEND regulations, that you put down one primary need. So the 35%, I think it is roughly, of the primary need was social, emotional, mental health difficulties. And then around about 30-ish% were autistic spectrum condition. So out of those, a significant proportion of them are known to sort of CAMS services. So you can see that what I'm getting at here really is that there's a massive ask on CAMS services to support these children and young people, but also for advice for EHC panel. And the other sort of chart that I've displayed here is the amount of teams involved with these children and young people at panel when they come to panel. And 2/3 of them have 2 or more health services involved. So that, in addition to the GP, obviously, so that may be CAMS and speech and language, for example, or it may be CAMS and cochlear implant service at Bradford, for example. So it's not just local teams that that we need to sort of support and get information from. It's sort of regional and national teams as well. So I think it shows you it's quite complex. It's much more complex than I anticipated, to be honest. But yeah, so it's all in the report for you to peruse over. I just thought it'd be helpful to sort of outline sort of the next steps really of my plan. As Michelle and I said earlier, there's this written statement of action, and the revisit is likely to be January, February of next year. So we're very busy preparing for the revisit for a local SEND inspection in CYC. North Yorkshire Local Authority are preparing for their inspection sort of spring next year, so we're involved with both sort of local area inspections and preparation. But the day-to-day work continues, and so continue to be sort of core member of the panels. So that's sort of something that's ongoing. Obviously, the quality improvement work that I do in relation to auditing plans will be ongoing work. And there's some specific work that hopefully will be short term, that, for example, I'm putting together some exemplars of good quality advice for CAMS. Currently, I'm working with a sort of a regional NHS England lead to write examples of good quality advice for CAMS colleagues to try and make it a bit easier for them. And also myself and the DCO at North Yorkshire work together on a training package for for SEND, general SEND and purposes really, that we have shared with local health providers in the hope that they will incorporate that in their statutory mandatory training. We basically want to make sure that SEND is on everybody's radar and that it's treated as everybody's business, a bit sort of like safeguarding is. So we are really flying the flag for SEND really. I think that kind of sums up really the sort of next steps for me. Just thank you everybody for giving me the time, and I'm happy to take any questions.
Great, thanks very much, Louise. Really excellent presentation. Thank you for being with us. So one thought for me would be how it's been to come into an organisation during COVID, more from a personal perspective, and how's that felt coming into a new role, and then we'll open it up for other people to comment. Thanks,
Nigel. Yeah, I mean, I think I've worked in sort of provider land acute services for forever, really, and so the change has been much bigger than anticipated, and then that on top of COVID and working like this, you know, it has given some difficulties, and I think it takes a bit longer to get to know people. And I have a bit of a sense of humour, and I'm having to sort of remember that it doesn't always translate on Teams as well as it would face to face. Personal learning point for me. But it also gives lots of opportunities. You know, I've met colleagues working, you know, down in Cirencester and Liverpool, you know, and it has, you know, lots and lots of opportunities for that sort of national working. And as Michelle says, you know, the close working between North Yorkshire and York, I think that's much easier doing it virtually because, you know, we're not having to travel, and we're all finding that. So, yeah, I think there are some positives and some kind of downsides to it, but I think generally I felt really well supported by the team. And, you know, Michelle and Paula are, you know, even though Karen's gone, I still know that I've got them as support. So, yeah, thank you. Great. I'll open it up, Penny. Yeah, Julie's going to.
Can I say thank you again? You haven't lost anything in your second presentation there, Louise. Really enjoyed it. And I think for me, the bit that really stands out is when you look at those two pie charts next to each other, and you see the implications of potentially, if you think that's one person that's part of that, and then on the other side where one person accessing a myriad of services, and how we have to make all of that work together. Brilliant work that you've done despite COVID, and yeah, I like your sense of humour. Thank you.
Thank you. Great. Anybody else? Yeah, Phil.
First thing is to concur with you, your reflection about all the acronyms. When I joined this organisation a few years ago from policing, it did feel at times like I was having to learn a foreign language. But all professions are the same. We all use huge numbers of acronyms without even realising it. Second thing is you talked, and you aren't the first, you won't be the last person this morning to talk about the increasing demand for services in your area. How much of that do you think is about there's just more people out there that fall into the definition of special educational needs or needing services around SEND? And how much of that is that you're just better at it? You know, the services can diagnose more complex, more hidden conditions. So as experience and expertise improves, so the net gets wider and the mesh gets finer.
Yeah, thank you. And yeah, I think it's difficult. I think the 2014 reforms, the Children and Families Act, so that's quite a long time ago, really. But so children prior to that would have a statement of education, and it was very much education led, and the health elements hadn't been sort of considered as important in that. But the reforms back 2014 sort of changed that, and I think health teams have slowly but surely recognised that they do have a place to play in providing that integrated sort of care around that child and family. So I think there's some of this sort of increase in access to services and workload is because of the reforms and the way that they've been rolled out, and the recognition that we need to work together across services for the benefit of children and people and their families, really. I think that we do know that numbers of children and young people, say for example with autism, is on the increase. So there are increasing numbers of children and people with special educational needs and disabilities. And it's about them accessing the right level of support, and whether that's like a universal level of support or sort of more sort of targeted and then specialist levels. So I think that sometimes the universal, our service, sort of acute services are referred on to and accessed. Sometimes if there's a lack of that universal service to sort of plug that sort of low level sort of need. And I think sometimes that's happening. But yeah, it is an increasing level of SEN, an increasing awareness, and also the fact that we are sort of mandated by the Children and Families Act to work together. It's a must do. And prior to that, it was like that would be a really nice thing to do. But now it's, there are no options about it. So I hope that answers your question.
Yeah, thanks, Louise. Thank you.
I think it was Chris and then Michelle.
I think you just answered my question, actually, Louise, with that last statement. I'm Chris, I'm a GP in Yorkshire. I was going to ask, I was going to say really that, the work that you do, I can't imagine many other areas where it's so many different partners to coordinate and work together. And I was just thinking about what we're moving into, and we're going to have to do more and more of that. And I was going to ask if you've got any nuggets for how you do that. But you just said it's because you're mandated. People have to do it.
Because we have to.
So maybe that's a good thing. Maybe the ICS is going to help us. We're going to be mandated to answer the question. But if you have got any reflections on how you get people in a room, virtual or otherwise, to work together, that's really valuable insight. That's one thing I was going to ask. And then the other thing was, what are we as GPs not doing to help you that we could be doing better?
How long have we got? No, I'm kidding. So I think the point about working together across, with moving on to ICB and ICS world is quite a good point. And I think, as Michelle said, our example of working cross with North Yorkshire. So we've developed sort of like a standard operating procedure for each of the local authorities to be able to use and access our health providers. Myself and Sally, who's a DCO in North Yorkshire, we're doing sort of delivering training together for providers. We are we're doing sort of send self-evaluations with providers together. So I think that it's early days with regards to that, but there will definitely be some good sort of learning points, I think, from that. But as you say, it does help when you are mandated, so services are mandated to deliver. So, and then the other point was about GPs, and actually that is something that I haven't quite got a full handle on yet. We're focused sort of solely on young people who are accessing sort of acute services, but it does come a point where those young people are discharged because they've got to the end of the paediatric journey, for example, and do go into GPs as their main sort of provider. And those are the areas that I need to have a look at in more detail, because we do require information and health advice, and within the NHS contract, providers are contracted to provide that, whereas I know that it's not within sort of GP contracts to provide that advice. And but in the times I have had to have sort of conversations, I do a bit of casework management, and I've had conversations with GPs. They have been really helpful, actually, and have been able to provide some advice. And if it's sort of statutory advice that I've asked for, I've offered sort of support to individual GPs, and just said, because it doesn't happen so often, it's you wouldn't be asked on a weekly basis like CAMS would be. So I've said that I'm able to help you write that advice in a way that's sort of helpful for the local authority. So what I do in those instances is that if it is a GP, then I'll ask the local authority to email the request to the GP and CC myself into it, and then just send off an email saying I'm available to help you sort of put in that advice is required. Some people have asked me and some people haven't, have just returned advice. So I think I have thought about how to sort of promote, because I don't think GPs know that I exist really, except the ones that I've had individual dealings with. So I have been sort of thinking about how that could work. So I'm happy to sort of work alongside yourselves to promote the role really and support where I can.
Great. Brilliant, thank you. Last point from Michelle.
Thanks, Louise. Just a couple of points from me. So behind Louise, and I don't know if she mentioned it or not, because I have to recall, those are the SEND outcomes that our children, young people and their families developed for our SEND strategy, which is in your pack today. And she's dodged out the way, but the I am healthy bit is really important to children, young people. So we mustn't underestimate the health element for these children, young people, and it's the number one importance for them. They've said that themselves. And in terms of that opportunity to work on a closer system footprint across our ICS, there are obviously 6 local authorities, 6 Ofsted inspections, and they're all about to bubble. So we got a written statement of action. North Yorkshire expected to be inspected soon. North Links got the call 2 days ago. East Riding awaiting their outcome. So there is a huge opportunity. It's the same framework that they're assessed against for preparation for SEND, so people get it right in the beginning and learn off each other. And then when you get a written statement of action or any actions you need to take that's recommended by Ofsted or must do by Ofsted, people are already working on that. It's somewhere in the system, but it's not necessarily networked together. So there is huge opportunity to go further than the North Yorkshire and York model and go right across. And Louise has already made those connections. So opportunity is huge.
I love those 7 5. I think they're applicable to all my patients all the time. Aren't they? Brilliant.
Really good, aren't they?
Yeah.
And I don't know if you said that, Michelle, but they were co-produced. You know, these are what children, young people and their families said was most important to them. And, you know, health have got a role to play in quite a lot of them. You know, I have a choice and I am heard. You know, it's you know, it's not just about being healthy and avoiding disease, is it, as we all know. So yeah, they're very pertinent to everybody. But yeah, super.
Brilliant. Thank you very much, Louise, for coming today, and thank you for all your work. Absolutely brilliant. And hopefully we can keep close to that and see how it develops over the next few years. So thank you again.
You're welcome. Thanks very much. I'm going to leave now. Thank you. Bye.
Okay, thank you. Okay, one thing that I forgot to do right at the beginning was about declarations of members' interests in the business of the meeting. So apologies for that. So if there's anything that comes up as we go along, and I don't think there has been so far, please let me know, or if there's anything else we need to do. So we've jumped around, but we're back on track with the agenda. We're probably a little bit behind time, so we might go over 10, 15 minutes. But we're going to go to Michelle now for quality and patient experience report.
Thank you, Nigel. So I'll just pick out a few bits, assuming that you've read the report, and as always, it's been through quality and patient experience committee, and then adapted the audience here. So I suppose the overall message is that there are incredible workforce issues right across the system, and with the increasing demand and the backlog of need, I can't portray not to do what pressures people are under in health and social care everywhere. And we're seeing elements of the system who didn't traditionally struggle with staffing, really struggling with staffing now. And it's simply not available, however hard people work. In terms of care homes, what we are seeing is nursing homes choosing to convert to residential because they can't get the registered nursing staff. And then when there are gaps in registered nursing staff provision in nursing homes, it's very fragile, and the agencies are stretched. And there are risks to having agency staff and not that continuity of care and huge gaps in the workforce. And sometimes that has led to very urgent and very tenuous discussions about the fragility of whether that home can stay open today. And sometimes we get away with it by the skin of our teeth, and on occasion we have had to move patients really quickly, which is always a very difficult thing to do. The other pressure on care homes is the mandatory vaccination that came in on the 11th of November. It's now enshrined in law, and as the registered managers, they are legally responsible for ensuring that anybody that comes to visit the home, so that includes general practice, for example, workmen, district nurses, anybody, needs to be able to show their vaccination status. And sometimes people don't comply with that very well and refuse to show their vaccination status, and that's hugely unhelpful. It's small numbers, but that will mean that they have to make a decision at the door whether they trust what somebody's saying to them, when there are very easy ways to tell people that you are vaccinated. So I would urge people to really help the registered managers who've got that legal responsibility. It just makes things really much more easy. And sometimes they make the decision to turn that person away when they've asked them to come, but to deal with a patient issue. So I would urge that. And of course, we've lost some staff who have chosen not to get vaccinated from that workforce. There is potential for further investment with winter monies that's badged with discharge that's coming nationally, and lots of discussion with councils going on about how best to place that money. And I think we need to support our social care colleagues in the way that they support us with care homes and domiciliary care, sheltered housing, supported living, and look at that as if it's one attempt to try and improve things together. Steph's very eloquently talked about vaccination, so I won't talk about that. Primary care, we've heard very eloquently as well, very, very stretched. The helpful thing, I think, about on the back of the push to get vaccinated is that the CQC have agreed to temporarily suspend inspections of primary care. So that's hugely helpful. The added pressure of getting ready for a CQC inspection can't be underestimated, so we welcome that. And again, there's detail about the winter access funding, which is about £5 to £6 million across the ICS. So when you break that down per practice, it's not a huge amount of money, but there are set criteria that you have to meet in order to be able to enact that money. And the Primary Care Collaborative is working through the detail of that and making sure it gets to where it's needed. With those profound operational pressures, of course, there are increased risks in the system, and we are seeing that in the ways that we usually measure, and from soft intelligence too. So what we are seeing is increased harm to patients, increased falls, increased pressure ulcers, increased incidents of impacted delays, and as you will see all over the news, huge ambulance waits outside hospitals. And so, you know, it is worrying all round, and people are trying their absolute best to meet patient need, but it isn't always possible in a timely manner, and we're seeing the impact of that. Nigel mentioned there's some work going on around system ethics. Nigel and I are closely involved in that, and we have set up the first panel and are working with partners right across, including primary care. We will get to you as quite a lot of people to talk to about it and try and get it embedded. It's supposed to be a really helpful panel where you can bring system issues that you might not have the headspace or capacity or skills enough to think about things through an ethical lens. And we've got medical ethicists with us, we've got local authority with us, public health with us, and we will gladly produce some recommendations. We can't make decisions, but hopefully it'll help people see things through an ethical lens. And some of the pressures and issues that Vale bring to the ethical panel will be the same everywhere, and they will all be battling with it. And some individual organisations have their own ethics panels, and actually, again, with that system working, there is perhaps one way that we could do that together and have that network of ethical experts. The SEND strategy is in your papers, so you'll see that that's been approved. So that's for information, and I want to commend the work of both Louise, but especially Susan Vale in that, who's a force of nature with all things to do with SEND and mental health children in particular, and we couldn't do without such sterling work there. We've heard about the question at the beginning of the session that came from Virginia about the concerns around maternity services, and we've described it within your papers about how pressured that particular area is in a way that we haven't seen before, and it's not specific to York, but we are keeping a very, very close eye on it, working alongside them. But we are so significantly concerned that we're asking governing body if they will adopt that risk, because it's increased from the score that would normally be managed by a quality and patient experience committee. So if you agree to that, we'll adopt it to the risk of the governing body, and then make sure that you hear about mitigation on a regular basis here. I'll wait for some nods around that, if that's okay. In terms of infection control, so not just COVID, we are seeing rises in what you would normally expect in terms of winter viruses and C. diff, for example, and norovirus. But there are particular concerns around Scarborough Hospital. They have traditionally had very difficult estate to manage, and some ingrained issues around the management of infection prevention control, not least the ability to recruit specialists who can support that organisation. And they've had some external support to give them some pointers in how they might improve, and we're working alongside them to make sure those actions are embedded as much as they possibly can. In terms of mental health, our biggest concern remains TUVE, TSS Weir Valley Trust, with very long ADHD waits that we understand much better than we did before. I don't know if Denise wants to come in and embellish that. But there is inequity in the waiting lists across the patch, particularly in the Selby area. So we are working very closely with TUVE to get that assurance and see the improvements that's required for that specific cohort of people. I don't know if you want to add anything to that.
I think I probably want to put it in context in that they, TUVE have been working probably for over the last year to share much more detail on waiting lists. And as you'd expect from a big provider, they'd want the information that they gave us to be accurate rather than estimate number of lists. So that has taken some time to clean that, and they were very clear in the first instance that we wanted to understand the waits for people who were waiting for cancer services, and then understanding once it's the number waiting for a cancer service, but then when they've had the original assessment, how many are then waiting for the treatment subsequent to that. And so in a balanced way, they have started to give us much more detailed information, breakdown of those levels of wait by month bandings and everything. And we did also, and they then also agreed to move on to look at ADHD weights, autism weights. But it was only recently that we discovered that there are some quite significant long waits in ADHD. So they are now working to get the level of detail to share with us on that. There's reasons for it. I think many of them have been covered by discussions earlier. There have been really long-standing recruitment issues for the specialist clinicians that are required for that. There are higher level numbers, but actually when you do look at the numbers, there are more children waiting for the ADHD diagnosis in the Selby patch than elsewhere. So they are again trying to balance that out. But as we've discussed earlier, then the level of recruitment is a real challenge across all the specialties in TUVE. I think that's probably all I'd want to say.
Thank you. That's really helpful, that context. And we've talked here openly about the concerns following the CQC inspection of TUVE, which continue in terms of their ability to address the actions. And there are some very positive responses to some of those actions, but it will take quite a long time for them to address all of those. And then, of course, subsequently to the June overall CQC inspection of inpatient services, they've subsequently done forensics and CAMs and found wanting in a number of areas, and we await the outcome of the well-led inspection, which is due any minute. So they are under significant pressure, not just through their day-to-day operational issues, but the additionality of the regulator. And so, as would be normal practice, the quality board has been stood up by NHS England. That continues on a very regular basis. But important, I think, the intensive support team from NHS England has withdrawn from that organisation now, because it is a time-limited support that they give. A couple of them are spending some longer time there to help them with their serious incident processes, which remain a concern for us. And again, it's about the workforce to be able to manage how you attend to a serious incident, investigate it, and importantly get the learning out. There's a long backlog, and of course there are more serious incidents happening at the front end, so we're keeping a very close eye on that. In terms of the risks that come to QPEC, you'll see them detailed within the report. The ones that they're pretty stable, there's nothing more to say. We're keeping a good eye on those. We've got good assurance about how we're managing that risk. And the risks that come to governing body, The hepatitis B issue is, we think, finally resolved in that York Hospital has taken on the contract for that. There are people between two stalls, but we've got assurance that they're being managed well. So those that have started treatment will stay with primary care until they're completed, but any new ones will be taken over by that new contract. So we're asking governing body with the reduced risk for that to be now managed by QPEP and taken up here. North Yorkshire County Council's review of their 0 to 19 service and their new service, we included in the pack the presentation of the new service. So I don't know whether governing body want to, now that service is agreed and developed around the consultation answers that people submitted. And we do think they have adapted as much as they can to address some of the concerns that we had around that, but we're just going to have to see what happens because it's only just starting. And the workforce pressures are very significant when they'd already cut a good 40 full-time equivalents from that service. So I think I'm not assured yet that everything's going to be fine, but you've got the information you require about what the service now looks like. So it would be good to understand whether you want to keep it here as a governing body risk or let local patient experience manage that.
I mean, what really struck me is it's a thin back service. Whatever you wanted to say about it and the design of it, it's thinned. It's making cost of savings or whatever it, so it's less than existed before. It's very difficult to be able to say that that's going to be as good as. But the one thing that was really important to me, because it's the thing that I'm experiencing in clinical practice, is the emotional support work that goes on with school children, because that's really, really important and such an issue right now with the children going back into school after such and through a significantly disruptive period. So that did seem to have been addressed. The one thing I thought was, how am I going to explain this to my colleagues so that they really understand this? Because the term school nurse isn't going to work anymore. And I think there is a gap there. We're going to need to try and explain this, and it's going to take a few years for people to get their head around what is and isn't there. And I suppose from the services perspective, be patient with the clinicians who don't understand this. Because I can see that everybody's going to be saying, I've spoken to the school nurse for about 5 years until they recognise that this is a different system.
And do you feel in general practice you've had the communication required in North Yorkshire County Council to help you understand that and help other people understand that? Because that's an action we could take away. And,
no, I don't. I mean, I didn't know about it until I read the report for this meeting. So, I don't think. And this may be about an explainer, somebody producing an explainer, maybe coming in, visiting practices or holding meetings. I think it's more than sending out a bulletin, because the bulletin, given what we've discussed, will get lost in a whole load of more urgent stuff.
Yeah, that's helpful. I'll take that action. Okay, thanks for that. And we've talked about maternity here in terms of the risk that's now going to sit in the governing body, and Quality and Patient Experience also decided to do a deep dive on maternity services in January and give over the agenda wholly to that. And the Trust are going to come and present, so we've got that open dialogue with them, so we'll probably get underneath it. And we've made a couple of visits to them, we'll continue to do that up until and beyond the deep dive. So that's all I was going to just bring out from the report at this time.
Yeah, thank you. Anything else you want to pick up on that particularly? And with regards to the risks then, especially that last one around the North Yorkshire service, where do you think that should sit?
I'm sensing it should still sit here until it's just being implemented. And of course they are then it's not going to be as described, because they too have significant workforce issues. So I think we're just going to have to see. I don't think we've got the assurance that the risk is reduced. So my gut is to tell them to keep it here until we know more.
It's more turbulence and people jumping ship. A redesign, it will create exactly the same problem that we've described everywhere else. And when there are so many gaps somewhere.
It's worth saying, just because it just reminded me that CQC inspected the 0 to 19 service for York recently, and they got a lot of very positive feedback. And there are differences in the service model, and we would want to really keep those, I think. So we are bringing that report to QPEC next time, and then it will flow through here. But there's some really good messages within that inspection that they've just recently done.
One of the other big gaps in clinical practice is the interface between safeguarding professionals. You don't get anybody from those teams come into practice safeguarding meetings. Used to. I know Christine's on the call, but she would know. But there's a massive gap.
Well, I'm glad you raised that, because you'll know that one of the mitigations that we had around the safeguarding meetings that happen between primary care is that we funded another nurse to be able to plug that gap, because primary care can't always make those panels. And I had an email last night actually requesting that goes into the North Yorkshire patch, even if it's not in our CCG area, so Bradford and Craven, because it's in the North Yorkshire County Council area, where the issue of the change to service was the thing that initiated the extra resource. So why wouldn't we? Because it's about that boundary. So I've said yes to that. It shouldn't cost any more, but what they're saying is they want to also service the GPs that go into that North Yorkshire County Council boundary. So hopefully that will improve, but like I said, that's an idea.
Our existing safeguarding meetings in some, not all of our practices in our PCN are, a health visitor plus a school nurse plus a GP plus, a midwife. So the midwives aren't attending. The health visitors do still attend, but this is going to change under this model. School nurse sometimes attends, but then we've had a gap because there hasn't been anybody in post. So we haven't got an MDT for safeguarding that was supposed to be, I think, we're talking about four plus years ago.
So you're not talking about the panels, you're talking about
no, these are about day-to-day management of safeguarding. You're supposed to have an MDT, but safeguarding, you should really do it for safeguarding adults as well as for children, but certainly for children. And the thing is, we now live in a smarter world where we have teams, so it is much leaner to be able to attend and to be able to have all of the cases discussed in a remote fashion, which should be much more feasible. I'd be really worried about losing that, and I think there's something in the model of who's the person then that attends in that team structure. And it was an opportunity for the health visitor and school nurse, as was, to be then discussing the transition, or one person would be seeing the 3-year-old in the family and another person would be seeing the 11-year-old in the family, and to bring that conversation together.
Yeah, I think you're right. So let me raise that with North Yorkshire County Council in terms of the mechanism to understand the service better with an explainer and additional information in different formats, and ask the question about the MDT under this model who is going to attend. And if the answer is we can't, then how are we going to get that connectivity between the 0-19 service and the rest of the community?
It should mean that the information has flowed before Louise gets involved for those sorts of discussions. That the other people in the room have got that information from the GP, and it should be a much smoother process.
I agree with our safeguarding issues. Christine's on the call, so she'll hear that too, and is in that integrated adult children team, so we'll get that conversation.
Great, thank you very much, Michelle. So we're requested to determine whether we're assured of the work being done is to support the quality of the services, so those risks and the decision log. So I'm saying that's yes, that's fine, thank you. Okay. And Michelle, also for you, there was a COVID update. I don't know whether there was anything particularly you wanted to highlight.
With this conversation,
yeah.
Sharon can't be here, but you'll well know the rates that are happening, reducing generally in York. However, absolutely heightened awareness to the new variant and the changes indicated by the Department of Health that we should undertake, and that particularly is increased use of masks and social distancing, and all the other elements still should be there, but the vaccination program is so important. So nothing more to add.
Great, thank you. So we're now over to item number 9, Board Assurance Framework, and Abby's come to join us. Thanks, Abby.
So Board Assurance Framework, as always, the updates are in red. There's a couple of bits that I just wanted to mention. I think some of this is to do with the fact that obviously we get this ready for some of the papers and things change in the meantime. So some of that is the things that Michelle's just been talking about in terms of update on risk. The other one is just on page 101 of the papers, which is to support the wellbeing of our staff and manage and develop the talent of those staff. We've got in the last box that the direction of risk travel is stable, which I think is probably right in terms of process, but we are starting to see an increasing number of staff looking for other opportunities or leaving the organisation, so that risk is probably increasing. The only other thing that I'm going to pick up with Peter Roderick later is we haven't identified any risks that are firmly population health, which seems a bit of a weird place to be given that we're supposed to be focusing on health inequalities and population health. So I think there will be some. I think we're probably just not framing them as population health risks. So I'll pick up a conversation with Peter about how we can refresh that for the next time to provide papers. Other than that, I think it speaks for itself, unless there's any questions.
Yeah, anybody?
That's fine.
Very clear, and we did talk about the impact on staff earlier on as well. Yeah, so that's great. Okay, thank you very much. So we have reviewed and received that, and then you're on again, Abby, I think. This is emergency preparedness, resilience and response policy.
Yeah, so this is as riveting as it sounds, and you'll all be grateful that David is the responsible chair for this. So it's already been through FMP, and David has gone through it with a fine-tooth comb, haven't you, David?
Thank you, David.
Absolutely.
Yeah.
I know it backwards.
So on the 29th of October, we were required to submit our assurance standards for EPRR to NHS England, which we did, and it went through Finance and Performance Committee as is delegated from this governing body. As part of that, I reviewed the CCG policy and inevitably the national risks and our local resilience forum risks have changed as a result of the pandemic. So that was the most significant change to the EPRR policy. It just needs to come here for you to sign it off. I've already submitted the return to NHS England. I've forged Phil's signature on it. It has got today's governing body date on it. I haven't really forged Phil's signature. It has got today's governing body date on it, and they knew the reason it was delayed coming to the governing body. So you just need to have received it, but obviously FMP signed it all.
Yeah, great. Thank you.
Has my full support, obviously.
Yeah.
You don't know it. Trust me, it does.
Always surprised it. Phil looked just ready to run out the door. I said, I forged. You think, I haven't really.
Just check with us.
Yeah.
Just check.
Yeah.
So yes, you just need to receive this.
Brilliant.
Make sure.
Even ratified. Yeah. Happy with that. Brilliant. Thank you very much.
Thank you.
Okay. Great. So we're probably back on track, but not far off. So we're now over to item number 11. And Christine, you've joined us virtually, so thank you very much for attending. And I think first of all, it's the North Yorkshire Safeguarding Adults Board annual report. And then also you've got the mapper as well to go on from that. So I don't know whether you want to do the two together or whether you want to do one and then go on to the other. Up to yourself, whatever you think flows the best.
Shall I do one and then see if anybody's got any questions and then do the second one? Shall I do the Safeguarding Board one first? And I haven't got a huge amount to say on either of them. You'll be very pleased to know probably. I'm just going to try and share the screen. Has that shared at all?
Not yet.
Not yet.
No. Okay. See if I can do that a bit better. All right, did have this quite well planned, I thought. Is that sharing now?
Yes, yes, brilliant.
Yeah, and I thought that just might be useful just to kind of save you having to stare at me really. Gives you something to look at. So it's the one-page summary, and you've got three formats of the Safeguarding North Yorkshire Safeguarding Board annual report. The board's made up of 23 partners. they've got 3 duties under the Care Act. One is to produce a strategic plan. The second is to produce an annual report detailing delivery of that plan. And the third is commissioning a safeguarding adult review. And one has been commissioned this year and one has been completed. They're separate ones, not the same one. So I hope you'll agree that you've had time to read the report and that it evidences really comprehensive delivery of the plan. There are 3 subgroups of the board who do the kind of operational work really. The PPDL, the Policies, Practice Development and Legislation group, I'll just highlight a few bits from the subgroup. I think what's made a key difference is the risk notification return guidance system that's been set up. So this has been a new tool that's been developed for care homes and domiciliary care agencies to really notify the local authority when there's an incident within their care setting. And there might be falls of residents, there might be meds errors, etc. Where there is no harm, but some action has needed to be taken. And these used to come in as a safeguarding concern because there was no other mechanism for the care home to actually notify anybody. But now they go to the quality and contract monitoring team, which means that the care provider still has to demonstrate what action they've taken, that they've taken appropriate actions, and that's followed up by the contracting team. And support given if support is needed, and obviously where they see a higher number of returns coming in, then it kind of signifies that something may be wrong. So it gives that early identification. It also means from a safeguarding perspective that what comes into safeguarding is more appropriate in terms of then leading to an inquiry process if needed. The other thing I'd like to highlight is the persons in positions of trust. They're all very difficult things to say, lots of P's. So that's guidance. It's in the Care Act stipulated as being required, but very little else is in terms of guidance as to how to enact that. But essentially it's responding to and managing allegations that may have occurred in somebody's private life, in somebody's personal life or work life, not necessarily against somebody with care and support needs, but it may mean that because of that they are unsuitable to work with adults with care and support needs. And similarly, obviously it's more well established within children's services in terms of the ladder, the local authority designated officer. CCG, as you'll know, has its own managing allegations policy, and that sits alongside this process. So that's become more well established in the last couple of years, and we are kind of reviewing that at the moment, actually, that guidance for the local authority. The Learning and Review subgroups completed a SAR, Safeguarding Adult Review, for a lady called Anne. We don't use, we pseudonymize the names. They're huge pieces of work when they're completed and take many months to conclude, and we're at present just going through embedding the learning from that SAR. And the Performance and Quality subgroup scrutinises the data that's collected and carries out case audits, etc. Ensuring that practice really is where it should be, and takes action where it isn't. And it's highlighted in the report really the increase in making safeguarding personal and achieving outcomes for people that they have expressed themselves in relation to the concerns that have been raised. So it really is sort of helping people to manage the risk that is within their lives. I think one final thing is the newly developed joint engagement and communication strategy, which has been hugely successful in raising the profile and accessibility of the board and its publications. So working with advocates and self-advocates from the learning disability community, we're particularly proud really of the easy read versions of the documents, including the board minutes and this report. So I won't say any more on that. If anybody's got any questions, I'm happy to take them. But I've heard your kind of concerns in primary care around safeguarding. And I think just to say these things are not going to go away, are they? So I think we do need to find smarter ways of sort of pulling the information together about people. And I'll sort of take that forward as a sort of piece of work for next year with the primary care team.
Yeah. Thanks, Christine. Julie.
Christine, you already mentioned this, and I've already said this to you. The easy read version really was, you know, a wonderful piece of work, and for me was invaluable. And I think what I really get and understand, and we know we've got a long way to go in safeguarding, is that it's the learning behind it and the fact that we have to learn more and that we have to work differently potentially, and that for the team is never a problem. It's okay, so that's not working, what are we going to do? And thank you for that.
Thank you. Yes, I agree. I think that the documents really have kind of, there's obviously been a huge amount of production around all of them, because even the kind of full version format I think is very well produced and easy to follow and read. So thank you. I'll take those comments back to the chair and the team.
I think one thing we've got is plain English in it,
yes,
which is good to see.
And that's one of the other commitments really from the board, is producing those. And certainly now, if you click through any of the links, the strategic priorities for this year, there is a plain English version of those on a kind of one-page summary as well. So it's just about getting the different versions out there really, and meeting people's needs so they are aware of, and we still get people who have absolutely no idea about, you know, that safeguarding even exists, and how to access it. So there's still a lot of messaging to go out there.
Thank you very much. I just echo Julie's thanks for the presentation and the report. I think it's really good. And also to you and your teams about the access that primary care has to you. I think that's really, really important. You know, when we're talking about interfaces, actually the interface between primary care and the safeguarding teams, just from the CCG, North Yorkshire CCG, I think has been really, really good. So just wanted to say thank you again for that.
Thank you.
Okay. Do you want to go on to the mapper, which I think is another interesting report, and people might have some questions on this.
Might be a bit slicker now. I've done it once. Is that showing?
That's there, yeah.
Yeah. Got there. See if I can move it on now. So you've received the MAPA annual report, and just as kind of a reminder really, that MAPA stands for multi-agency public protection arrangements. I'll try and move on. Yep, that's worked, good. The arrangements are there to manage the risk posed by the most serious sexual violence and terrorist offenders under the provisions of the Criminal Justice Act. I've put there just an overview really, that just summarises the responsible authorities are the police, probation and prison services, and then there are the other duty to cooperate services. And third sector is obviously also plays a huge part in the duty to cooperate and the support of MAPA offenders. So again, just a reminder of the offender management levels. There are 3 categories of offenders who are MAPA eligible, and then 3 levels of management. And you'll see from the report that most offenders are managed at level 1, where it's a single agency. That might be the police, it might be probation, or it might be a health service. Certainly our mental health services will manage some of the offenders. And we tend to get involved from a safeguarding perspective in the category 2 and category 3 and level 2 and level 3 meetings. And then the highlights really from the report. More work has been done in the last 12 months really with MAPA and counter-terrorism and the newly established National Security Division, and that was created following the 2 terrorist attacks in London in 2019 and 2020. 5 probation services, national security units across England and Wales and have been created, and we've one covering our region, which means that any offender meeting that category would be managed within that unit, but with the continued oversight of the Strategic Management Board. I think learning from the pandemic, recognition really of the gains from reduced travel across the county and much improved attendance at meetings with improved quality using Microsoft Teams for meetings. Also acknowledging some of the downsides really of things that may have been lost from that face-to-face contact. And the desire really ultimately to have a hybrid approach and keeping that flexibility. We almost can't kind of remember, can we, how things used to be more than a year and a half ago, but if we couldn't get to meetings, and particularly we as you'll know, we're a small team, and there may be meetings in Scarborough or Northallerton in Richmondshire, in Harrogate, in York, and often very difficult to get to in the course of a day. And the telephone contact was the kind of spider phone, and often very difficult to hear a large room full of people on that. So much improved in the ability for everybody to attend, but also if that hybrid approach will need some more investment into the technology in the buildings when they do go back to the offices. Domestic abuse, the huge investment in training staff across agencies. Domestic abuse offenders are often brought in at kind of level 3 for management. So these are people who may have had a conviction for something that doesn't necessarily make them MAPA eligible, but the level of violence to partners or members of their family is such that multi-agency management is required or requested, and so they do come into that arena for discussion and for sort of allocation of as much service as can be. Housing services and preventing homelessness, another big key factor really in the management of offenders, and that kind of appreciation really of the importance of the housing and the difference that makes to the quality of someone's life, and the reduction in some cases of reoffending. And then last but not least, I'll highlight the initiative developed in 2018 and now firmly established of sharing information that's relevant and proportionate with colleagues in primary care and secondary care. Processes audited annually, improvements have been made throughout that time, but it does mean that people can achieve their health outcomes, keeping everybody safe in the process. Hope you'll agree there are some interesting case studies that illustrate the work, and I'm happy to take any questions.
Thanks, Christine. Anything anybody wants to highlight from that? David.
Yeah. Hi, Christine. First of all, could I go back to your previous report very briefly about the safeguarding adults? I should have said that the Easy Read report I thought was brilliant.
Yes.
Which is we should adopt that as a guide for other things. Really, it was for people with difficulties. Thought it was a great idea. So well done for that, and we should think about doing more of that. Really.
Well, thank you. I was just going to say it is a challenge from the board for partners to do the same things within their meetings. Because the board meeting minutes are also produced in that way and put onto the website. So a challenge out really, I guess, to all partners.
Good, thank you. And as you mentioned, I thought the examples that were included in the report, in the MAPA report, were very, very helpful again, and brings things to life, doesn't it, when you can see what actually happens. So, I'd commend you for that. I was also thinking about, the point that Michelle made earlier, when I was having a bit of a moan, and Michelle said, well, don't worry, because people are already working on this, and a gap might need some thought about being filled. And I think this is probably one of them, isn't it, where we've got some, we've obviously got skilled people, with Karen moving into that other role. I think we can build on that. So really what I'm saying is that, keep the momentum going. And if you haven't got the resource, demand it.
Thank you.
We'll have to say David said. They won't back down then.
I need to get better at forging signatures.
Last probably point from me, Christine, is that of course level 1 MAPA won't get reported across other stakeholders, across agencies. So it's about level 2 now and above that does, isn't it?
Well,
or is that changing?
Although there isn't multi-agency management at level 1, there is still a duty to share information that is relevant about that. So if there is risk surrounding that person, then the agency that's managing that person has a duty to share it with the people concerned, and make a disclosure. So I think that's in place. I think we've had one example recently where that's not gone as well as it might have done, and we are looking into that particular case. But I don't think it probably requires any change in the process, because it is about kind of safe information sharing, wherever we have risk. And that goes across all our services and all across safeguarding, doesn't it? That's how we keep our services safe and people safe. Is that it's always a challenge to share the appropriate amount of information and maintain people's confidentiality and rights to privacy. But to safety and security has to kind of come top of that, doesn't it? And safeguarding people.
Yeah, absolutely. Brilliant. Thank you very much. Anything further? No? Great. Thanks, Christine, for joining us and presenting those. We've received those, so thank you very much.
Thank you very much.
Okay, so that's the most of the items on the agenda. Just that we've got the received items that have come in. That's fine. I'm just thinking if there's anything else that we need to highlight. Phil, anything from you?
Nothing else from me, thank you.
No. Any other business from anybody else? Okay, so we'll close the meeting there, just to say to everybody again, sort of from the bit at the beginning, which is kind and compassion, especially when you're trying to access services and get your boosters, really, wasn't it? So that's really what we're saying. So thank you very much, everybody, and we'll close the meeting there. And I think, Ryan, you're going to do the necessary on the Teams recording, is that right?